Clean it up. I mean, I need to get. Like, I don't have much hair. I look. It feels much better when it's
Well,
cleaned
you
up.
already had the quarantine cut anyway. So welcome to Recommend Daily Dose. I am your host, Dr. Clinton Coleman, along with my colleague, Dr. Suraj Saggar. What's up, man?
We are doing the responsible thing, and we
This is
are
the
broadcasting
quarantine
from
remote version of it.
respective homes. I think we both have a rare Sunday off from the hospitals.
So the last time we talked, which was about, I think, 3 weeks ago, just to give you some numbers, the total cases in the U.S. was about 164. Can you imagine that? And the
It,
total deaths was 11. So now, like I just checked this morning,
yeah,
um, I think worldwide it's up to 1.2 million.
yeah.
And how many? Let me just check the facts. I looked it on Yahoo.
Great site is the John Hopkins School of Public Health heat map.
Okay,
Also, Google has one as well.
right. So the last time we talked, it was 3 weeks ago. We had total cases in the U.S. 164. Now we're up to 312,000 confirmed cases. We
Hmm.
had 11 deaths. Now we have how many? 8,500, which exponential is probably not the word, but it over at some point we're at the steepest part of the curve, I think. And we know
You
the
know,
hospital has
that's
been crazy.
unclear
Yeah.
where we are on that curve. Just to give a little good news, today was the first day in New York they had a slight dip in the number of deaths. But it's unclear what that means. That might just be a reporting number. You know, that it's unclear. You
Right.
can't get too excited about what that might mean. But
But
um,
yesterday they had they recorded their most deaths, right?
that's right. So today, Sunday, April 5th, was a slight dip. But again, when you have such high numbers, relatively speaking, you're going to have some variation among that. So it's unclear if that really represents a downward trend or that's just a normal variation as the overall slope continues to go up.
And I think that total death number is probably skewed, right? Because they're only recording confirmed coronavirus cases and deaths, right? So what about the people who died from respiratory illnesses, who didn't have testing? So I have an idea that that number is going to probably double at the end of the day.
No, that's a great point. As we learn more about this virus, we're seeing that there is more systemic manifestations. So heart attacks, people dying in their sleep, strokes could all be attributed to coronavirus.
Right.
Personally, I've had a few patients who were recovering, we thought, and then subsequently developed strokes. You know, so were those strokes just incidental or were they related to coronavirus? What about pulmonary embolisms and DVTs
Right.
and thrombosis? We're learning more and more those with severe disease can have other manifestations, so other symptoms other than just the pulmonary, the shortness of breath, the cough, what have you, the pneumonia. So this is a complicated flow, and we have to constantly stay ahead of the information game, so to speak, and all the data coming in. You know, the great thing is we're all sharing data, but we're really, I mean,
Right.
what we're saying here today, what we said 3 weeks ago is already irrelevant a week from now. So every day we have to, reevaluate, retool, and figure out what's going on.
What do you think about the initially when we got the data from China, they were talking about older individuals who had other health issues, but now I know you've seen it and I've seen it. We see a wide range of ages, young people, old people, no medical history. That's pretty concerning because, I've seen as young as 19 and we've seen as old as 89. And it
Yeah,
seems
yeah.
like majority of the people coming in are middle-aged men between the 40s and 50s, and they're really sick. You think the lethality has changed since China? We see more of, I guess this is more of like the Italy's version of it.
Yeah, so Italy, it was thought had a higher death rate because they're the oldest population in Western Europe. Now, what we're seeing here is unclear. Is it related to misinformation from China? I mean, I don't want to get into the politics of that, but we
Right.
know they initially described over 65, 70, smoking, COPD, heart disease, things like that. We're seeing a younger population. I mentioned it before. Is it because we have higher rates of obesity? Because that's one thing we're definitely seeing an association with. Is it because we have higher rates of metabolic syndrome, so diabetes, heart disease? Is there genetic variations? So
Right.
China, right, we're a homogeneous society. Is it because we have genetic variations and just different ethnicities and certain people have certain, unbeknownst to us yet, risk factors for more severe disease? A couple things we're seeing is men seem to be worse off than women, and we can talk about why. We're seeing some associations with obesity. We don't have the levels of smoking that we do in China, but we do have more metabolic syndrome. So
Right.
nothing in medicine is black and white. So it's going to be a curve, but you're going to have outliers who have no obvious medical conditions. But at least early on, observationally, we're seeing obesity, diabetes, male sex as certainly risk factors for more severe
Lung
outcomes.
disease. Right.
Yeah, yeah.
The other thing was, I'm trying to think, what was the other thing? Oh,
There's
yeah.
a lot.
Yeah. I was reading somewhere. I was reading somewhere that they were saying that young people who don't have medical history can get a severe, response just because of their own immune response to it. So it's not necessarily the virus, but your body's immune system with
Yeah,
respiratory
this is a good
failure,
time for that.
ARDS,
This is a good time for that review of the immunology. You have the
cytokine
innate
storm.
immune
Yeah.
system. So that's just not specific, just things like mucus in our nose, things that our body uses to ward off invaders. Then you have the adaptive. That's when your T cells and your B cells. And males in general, younger males sometimes can have a more vigorous response. And it's paradoxical that vigorous response creates that cytokine storm that we've all been hearing about in the news. And it's actually that cytokine storm we're understanding that has responsible some of the very severe disease that we're seeing in people who get respiratory failure, get intubated. In your case, you're dealing with patients with renal failure. This all could be related to that cytokine storm. So there's actually two parts to this disease. There's the virus and viral replication, the early part, and the late part, which is the cytokine storm.
Right.
And we're seeing that sometimes males, even very healthy males with very vigorous and robust immune systems, paradoxically do worse than someone who's older with maybe more a blunted or more milder immune system.
So you think our probably focus on treatment should be the body's immune system as opposed to the virus? Because in my opinion, I don't think the virus is that lethal. It's the body's response to the virus with the immune system. You think that should be the focus of treatment?
A virus can't replicate outside its body, so it needs a host. So if you think about it, a virus is best served by not killing its host. So they're trying to adapt and integrate, become epidemic in a host, in our case, humans, without necessarily killing us.
Right.
But it's our body's response to that virus that's really causing a lot of severe disease. So to answer your question, it's really two-part. Early on, we look at antivirals, so the hydroxychloroquine or Plaquenil everyone's talking about, the remdesivir, perhaps the Gilead's expanded access drug we're looking at that was studied for Ebola, did not have good activity, but then had activity against MERS, which is another type of coronavirus that came out in 2015. But then the late stages, we're looking at a lot of different things. We're looking at monoclonal antibodies. We're looking at steroids. And there's still a lot of research to be done. Of course, other institutions, not our own, are looking at serum, convalescent serum.
Yeah.
That is antibodies from people who recovered.
Right.
So the optimal treatment is still unclear. I think what we have to let anyone listening know, despite what some of our politicians may be telling us, no one drug is a panacea at the present time. We need a lot of studies. We need a lot more information. And we want to give people hope, at the same time have the understanding until we get a vaccine, which is really our best hope for stopping this pandemic. The medications we have, while exciting that we're sharing this information and trying, nothing has been fully proven yet.
Right. The only issue with the vaccine, that's a 18-month, 2-year window we're looking at, probably.
That's right. That's
On
right.
the best case scenario, right? So, have you had any observational data or observations on hydroxychloroquine and azithromycin, like clinically?
I think most of my colleagues would agree. If used early, it may have some benefit.
Right.
May have some benefit.
But how do we
Later on in the disease course, if someone's already going down that cytokine storm pathway, the chance of that having any real meaningful effect is unclear, and probably, at least to us on the front lines, not very vigorous.
Right.
So I'm kind of speaking ambiguous because we live in an evidence-based medicine world, so it's hard for us to just give some medication, let's see what happens. We want to see the
Right.
data, but we don't have time for randomized clinical controlled trials. We have to try something.
Exactly.
But it's hard for me to speak in certainties until we really see the data. And the studies have been very small. It's all either non-randomized, non-blinded, all the things that we use in medicine to have good data in the evidence-based world we live in. So it's very difficult for us to really make sweeping generalizations.
That's a
Yeah,
great point. How do we know that it's not in the mild case of the virus that the patient's not getting better on its own, in addition to or
that's
is it
right.
the medication, right? So that's the importance of research and randomized controlled trials.
But as doctors, we always want to be able to offer something, especially in
Right.
something that has a potential. Again, not for everyone, not even for the majority, but for a not insignificant minority to have severe outcome. We want to be able to offer something. And we're constantly changing what we're doing. We were first trying old HIV drugs. That very quickly became apparent to us that wasn't helpful.
Right.
That was confirmed in an article in the England Journal of Medicine. Then we were treating patients that came to the hospital and not as an outpatient. Then we realized, hey, if we treat them as an outpatient, we can prevent them from coming to the hospital. So our treatment paradigms are changing constantly. But we know when the patients come in sick, some percentage of them crash and burn, as we say.
Right.
They decompensate very quickly. They go to respiratory failure. You've seen it firsthand, the renal
Of course.
failure
Yeah.
and the need for hemodialysis, which is unfortunately a bad prognostic outcome. So we have to figure out when do we intervene, and it seems the earlier the better. We can't, just saying go home and tough it out. For a lot of people, could be fine, but for a certain segment of patients, we have to identify that may not be the case, and those are the ones you identify and treat early.
Right.
Possibly benefit with Zithromax, which is an immunomodulator, and Plaquenil and zinc, which is Plaquenil being hydroxychloroquine, which work synergistically together to try to inhibit the virus replicating in the lungs.
And I think we've been skewed because we're in the hospital seeing probably the sickest of the sickest patients. But just to let everyone know, a majority of the people will get better on their own. Um, but from last week to the prior weeks, it's been such a drastic change. Even in our own hospital, we built out a whole new ICU with 30 plus
Incredible,
beds.
incredible transformation. Yeah.
Right. So I think we're at the max with the ventilators. PPE is always an issue. There was some people had a few questions about the PPE. How effective is PPE? Because if you look at the N95 mask, 95 means filters 95% of particles, right? What about that?
95%,
What about
right?
that 5%?
Well, before I answer that question, I think we got to give a shout out to all the staff at Holy Name Medical Center, right? I mean,
Definitely.
not the doctors, just the nurses, the respiratory techs, the EMTs. I mean, we're talking engineers, the
The transporters, the
consultants, the construction workers,
phlebotomists.
environmental people. I mean, to
Right.
put up these rooms that quickly, negative pressure rooms, whole units transformed, making auxiliary ICUs, it's really incredible. If you could joke for a second, it could be like the Academy Awards. You have so many people to thank. It's incredible. And this is obviously our own institution, but this is institutions across the tri-state and across the country
Right.
that are really, all hands to deck, so to speak. I mean, you're talking environmental. They got to change or clean the rooms effectively for the
Of
next
course.
patient
Yeah.
to come in.
Yeah.
I mean, because it never stops, right? I mean, I'm sitting in the ER, one patient goes to the ICU, and they have another patient ready to come in. They got to turn over the room. So everyone's got a part to play here, and
Yeah.
everyone's a hero, really.
Yeah. Every
Yeah.
day I'm impressed about the character and the reserve of, people I work with, including you and the rest of the doctors, but just, the staff is just the morale and rapport. It's such a good thing to see, while you're dealing with such, critical issues. Now,
Critical issues, and as you already know, heartbreaking,
right.
as we have dealt with some loss in our own medical community of colleagues and friends, and which unfortunately that story will play out, for some time. So getting back to the PPE, look, I make it very well known and very clear the safety of all the healthcare workers, first line responders, respiratory techs, nurses, everyone involved in patient care or could be possibly exposed. PPE is the most important issue, right? So we are lucky through very generous donations and as we raise awareness throughout our communities, people donating supplies, etc. So we're still ahead of the game here, ahead of the race. But then talk about things like vents, critical care staff, doctors. Believe it or not, I mean, we can have all the PPE and all the rooms and all the
Right.
vents we need, we need the healthcare staff to run them, right? So we've already seen call for arms, and there's thoughts about a medical draft, if you can believe it.
I saw
But
that. Yeah.
this is going to be a long slog, man. And I tell you, we're all putting in our time, and I'm nothing special, you're nothing special. Everyone's doing it.
Right.
But at the same time, we have to protect those in the first line. If we all get sick and and do the right thing and self-quarantine at home, you're going to run out of people to take care of patients. So again, first foremost, PPE for all, not even healthcare providers, but anyone with direct or indirect care of patients is a paramount status. Now, the N95 you mentioned, 95% of particles it filters out. We do feel very good that it's effective for both droplets.
So this is the N95, right?
N95. So that's a NIOSH, National Institutes of Occupational Safety Hazards approved mask. If they're made in China, I believe they're called K95s, but N95s. So, and made here. They are effective. That's what I use when I see tuberculosis patients, something that is airborne. If I'm seeing measles, which is probably the most infectious, or one of the most infectious disease you can have, especially in a hospital setting, we use these N95 masks. They're fit tested, so they have to have employees, doctors, et cetera, have to have been fit for them before. If you have a large beard, then you're going to use a different type of protective gear. But it's not just the mask; it's the goggles, right? It's keeping the head covered. Gowns, obviously. Now, as you may know, we're shifted towards disposable gowns to reusable gowns. Right. Very important. And of course, gloves. So these are all, again, effective tools. Now, of course, the next question is, why have so many healthcare workers gotten sick? Probably because of inappropriate use or inadequate availability of PPE.
Or not having adequate testing to know if a patient was actually positive, right? So we've had,
especially early on, it was so tricky, so subtle.
In the ER, we had patients who had diarrhea, not necessarily the most common symptoms, but they had the virus. So the ER doctors, nurses were exposed without knowing, and then a few days later, 5 to 7 days in some cases, the test came back positive, and then you've already been exposed. Or providers are getting exposed out in the community, which we forget about as well.
Right, and they may not have all the PPE. I mean, it's almost paradoxical that in the hospital, we're so vigilant about everything. But especially early on, you may say, oh, you're in a doctor's office. This person doesn't look that sick, couldn't have coronavirus. Right. And again, that's why I talked about staying on top of things. A few weeks ago, our understanding of the virus was very different than today. Right. So now we know patients can come in with diarrhea, nausea, vomiting. They can come in with headaches. They can come in with change in taste and smell. They may have skin manifestations. They may have seizures and altered mental status. It's a tricky virus. It's not a straightforward presentation. We've had cases in our local community, and not our institution, another institution, of COVID-19 encephalitis, inflammation of the brain, the lining of the brain. So while we keep saying, yes, it's a common cough, shortness of breath, and pneumonia and fevers, it's a very wide spectrum of disease.
Right. What are your thoughts about other forms of protection? Like we have the regular surgical mask like this, right? And then
that's a nice big color, by the way.
Oh, thanks.
We
recently heard that, I don't know if it was the CDC or the federal government recommended everyone wear some kind of form of face protection, whether it's a scarf, which I give you my opinion later, or some kind of mask. But I guess, I was upset when I heard that because I don't want, random people on the streets buying up N95 masks when it's the healthcare providers who need it most.
So put up both masks if you have them. You have the N95 and the regular. So N95, which is in your right hand, that's going to protect the wearer against coronavirus. Okay, that's protecting the wearer. So if you have that, which needs to be saved for healthcare providers in the hospitals and the medical setting. The only time I'd recommend someone wearing that at home is if there's someone who's not infected taking care of a patient who is COVID-19 positive at home to prevent that person from getting sick. The mask you were just wearing is not going to prevent you from getting COVID-19. That's protecting other people in the community. If you're coughing, sneezing, from transmitting it to other people, transmitting other viruses like the common cold, the rhinovirus, human metapneumovirus, parainfluenza, influenza. So those masks like you just showing what the CDC is recommending, is augmenting social distancing. If you're truly social distancing and having proper hand hygiene, you really don't need the mask. But it can help if you're coughing and sneezing from expelling that out and infecting other people. Plus, it's a reminder not to touch your mouth, your nose, and your face. But we have to make sure people understand that's not going to protect you, the wearer, from acquiring COVID-19 if someone's sick around you. So the N95 does protect the wearer. But again, we have to keep that for our first-line providers. The only exception I can see, again, is if someone's at home, not sick, taking care of a family member or a friend who is COVID-19 positive, prevent you from getting that disease. And in that way, if this person who has COVID-19 at home is not that sick, we can keep them out of the hospital, but they still may need help with their medications, with getting food, etc., so the caregiver stays healthy. So otherwise, that's really important, I think, for everyone to understand the difference between an N95 or respirator and a regular surgical mask.
And it also doesn't mean that if you have a scarf, you can go outside because you're safe, right? It doesn't give people a false sense of hope that they cannot social distance themselves.
Right. But if you're sneezing and coughing, first of all, you should probably be home anyway. But listen, you have to get out. You have to get some groceries. You have to pick up a medication from the pharmacy. By utilizing that, you're at least preventing yourself from infecting other people. And maybe it'll remind you when you're touching surfaces, you touch a doorknob, you touch a grocery cart, then not to touch your face. Right. But again, if you're staying 6 feet away from people, practicing proper social hygiene, those things really aren't necessary. So but I think what it is, it's kind of getting people ready for a possible new norm, right? When things slow down, again, it's not going to stop until we have a vaccine. Or we have what we call herd immunity, which would require over 70%, if not higher, of the population to be infected, which would translate to a very much unacceptable amount of possible deaths.
Right.
And remember, we could be looking at a resurgence in the fall and winter of 2020. So I think people are obviously very hopeful that things can improve in the next few months, and they may temporarily most likely, but it's a very cautious improvement, and maybe very temporary at best. And we're still going to have to modify what that improvement looks like. It may mean people can possibly, I remember, venture out. But we still may need to still maintain ceasing to have sporting events, concerts. These are, again, I'm getting ahead of myself, but this is what people have to at least think. This is a long game. This is not a sprint, right? This is not Usain Bolt running 100 yards or something, right? This is a New York City Marathon. We're in it for the long haul, and people have to slowly but surely understand that. And we're facing very unprecedented social mitigation now. And that may relax in a few months, but by no means is anyone thinking that this is going to go back to normal anytime soon, our normal day-to-day American life.
So I just want to get an idea of where you think we are today. Like, have we peaked yet, or we have more of this to come?
No, I don't think we've peaked by any means. I think this upcoming week will be very challenging. I think a couple of things people understand is, like, when you peak, it doesn't mean you drop right away. You may plateau for some time, and that plateau still may be devastating in terms of its impact on our capability, our medical capability. We need to flatten that curve, obviously. But another thing to remember is that a lot of our patients that do get ventilated, that we're hopeful can come off, it's going to be at least 10 days to 2 weeks. It seems to be a very long process before patients are able to come off. So even if the incidence of new cases slows down, we're going to have such a backlog, so to speak. And I hate saying that for patients, but such a large amount of patients that are intubated. And we know that they are at risk of developing infections, secondary bacterial infections, line-related infections, urinary tract infections. So that's still going to be an incredible challenge for the medical community to take care of so many critically ill patients at one time. So just because it flattens and plateaus, which I don't think we're anywhere near anyway. And I'm hopeful, yet also realistic, that the levels of social mitigation are not uniform, right, in parts of the country for various reasons. And I feel as we may slow down, you're going to see other parts of the U.S. explode. We're already seeing large amounts of cases in Louisiana, especially New Orleans area, Detroit, Chicagoland, even Colorado. So all throughout the country. And each area is going to be differ in their capability to handle this medical surge. That's not to say that city hospitals are better than rural hospitals, but oftentimes it is true rural hospitals have less ability to handle large amounts of acute care. And you might say, well, if you're in a rural area, shouldn't they be immune to what's happening in the big cities? And the answer is no. I mean, oftentimes viruses and other infectious diseases hit the big cities first. If people are going to self-quarantine, guess what? A lot of them go to the mountain towns, beach towns, in the countryside to wait. And you might think, well, okay, people are kind of separated far from one another. But remember, all it takes is one person meeting another person in a grocery store, in a restaurant, whatever, for that to spread very quickly.
And it also depends. It also depends on their level of social distancing, right? Still have some states that don't have stay-at-home orders, so
or very late to the
their
game.
peak is going to be different from other places' peaks because they're doing different things.
It was only a few weeks ago that people were partying in South Beach for spring break. People were hanging out for Mardi Gras in New Orleans, and we're seeing the end results of that now. I think it will be uneven. I think states that may be less equipped to handle these type of things may have more devastating consequences. So again, these models are just models, just that. They're predictions. But from what I've seen and from what I've seen firsthand on the ground and from what I've seen from looking at these models in very analytical type ways, it would be foolish of me, irresponsible to say, well, the peak is soon and everything can go back to normal in a couple of days.
Right.
I think people, again, have to realize we're in it for the long haul. And I understand the socioeconomic ramifications, so does everyone else, which is why we have to make sure those that are most vulnerable in our communities are not taking risks just for financial necessity, not gain, but just financial necessity. I get it. People have to eat. People have to pay rent. That's why we need more stimulus. We need more support from all levels, central, federal, state, local levels to help those most at risk. Yeah.
And this term of peak, just to clarify, is new cases, right?
That's right. So the incoming of new cases. So once you have a huge amount of new cases, these patients are not automatically all getting better. A lot of them will, but the ones that require acute care, we're going to be in it, and you're going to be involved with difficult conversations about who gets dialyzed, and is it doing a difference? I'll be dealing with secondary bacterial infections, ventilator-associated pneumonias, central line-associated bloodstream infections. So this is something that we as healthcare providers have to be attuned to. That once numbers of new cases slow down, we have to continue the fight to help those already afflicted with severe disease to hopefully come out the other side in a positive way.
But this term of peak can be so distracting because it's just new cases. What about, and we're so focused on ventilators, right? We've vented all these patients, so the new cases may slow down. But remember, you've got people who've been on vents. A lot of people have been on vents for weeks. At some point, unfortunately, the mortality is so high that those patients who have been on vents way beyond the time that we peaked, unfortunately, will start to die. So that peak of new cases is going to be way different than the peak of deaths or mortality, right?
Right. There's going to be a lag between the new cases, and people say, "Oh, this is great." New cases have slowed down, but then you're going to see on the other end, unfortunately, some very disturbing and sad, results of this. Obviously, we have to keep thinking positive, keep doing what we can to treat patients, to get them out of the hospital, get them home, use cutting-edge medicine, clinical trials that we're utilizing, using drugs repurposed, approved by the FDA for this now COVID-19, so off-label use, running clinical trials. There's now interest in even other immunomodulators, so things besides Zithromax, colchicine being one of them. There's many trials looking at many different things, but then as a medical community, we have to make sure we share this information, that we utilize medications judiciously, at the same time that we don't give the public or the general public false hope until these medicines can truly be vetted. I think that's really take-home message here. We have a lot to be hopeful for, but it has to be cautious, and we don't want to just give claims when there's not the data yet to support them.
Good job. Any final thoughts?
One thing I'll say, and I've said it before, this is the first pandemic in the social media environment, and we're here coming, to listeners via podcast, but both as board certified infectious disease and nephrologist, as physicians, I would just be cautious of the amount of misinformation that we see out there. I'm sure you see the same thing.
Yeah.
And for people to really just pay attention to where they're getting their information from. Again, I don't have time to go through all these things, but when I occasionally do look through to connect to family and friends that I'm unable to see, my feeds are filled with a lot of misinformation that, as a healthcare provider, as a physician, I know are false. That a lot of people are using to make decisions, which could be very foolish. So I just implore anyone out there to really vet your sources of medical knowledge.
So for our listeners, what's a good source to get information from? Well, I guess your local health department and CDC, is that good at any other sites?
New Jersey Department of Health, the CDC, of course, the WHO, the American Medical Society. I mean, I'm part of the Infectious Disease Society of America, but that's more for healthcare providers. But going to your friend's uncle's second cousin twice removed, who was a political commentator a month ago, and is now, as they say, it's a little joke, infectious disease expert sitting in his basement, is probably not the person to trust. Looking at memes and thinking this must be true is probably not really going to serve you best. I mean, again,
why is basement such a dig? Like, if you say someone lives in their basement, like, is that supposed to be offensive?
I think now is offensive. I think usually when people move in somewhere, people shuffle them in the basement.
Got it. All right.
Are you in your basement?
No, I'm in my office.
It looks very nice.
Thank you.
Yeah.
And if you haven't noticed, we haven't been able to record some episodes, so I know you guys are anxious to see what we've been talking about. We do have a great few episodes coming up, but as soon as this dies down, we'll be back. So I'd like to thank. Yeah, go ahead.
No, I'll say I look forward to talking about anything else besides COVID-19. But I think
yes.
I think right now both our lives are consumed with treating patients, and again, that's our job, that's our calling. On a rare day off like today, I think it's worthwhile to spend some time to just disseminate information that hopefully people will appreciate, and not appreciate, but hopefully what people will find interesting and informative. Really, this is not the time to be entertaining, but to be informative. But I do look forward to when we can get back to just making fun of you, really building myself up as the brains of the operation. But until then, I'm very fortunate to work to work with you, because you're dealing with a lot of very sick patients. We know the patients that go to renal failure already, by definition, are extremely ill. We know that you're dealing with a lot of patients that you already know are not going to have good outcomes. So I thank you very much as helping all of us deal with this difficult situation.
Yeah. And if you haven't seen our previous episode, we talked about the coronavirus and answered important questions about, social distancing and hand washing and hygiene
and those things haven't changed.
All those things. So you can check that out. But you have to sign us out now.
Well, I tell you, it is a somber time for everyone, but we have to get through this mentally and physically. So as always, I'm your co-host, Dr. Suraj Saggar.
And Dr. Clenton Coleman.
And instead of broadcasting out of Teaneck, New Jersey, or lovely Fort Lee, New Jersey, we are at our respective houses. But we look forward to coming back to you soon with other topics. But in the meantime, please be well. Take care.